So chapter 16, nursing management during the postpartum period or during the fourth trimester. Make sure you note real quick that this time is very, very sensitive. They're very still, the parent is still vulnerable, and they go through there are physical changes that does take place after birth. Make sure you remember that after delivery, the birthing parent's body again slowly returns to normal, and that could take up to several weeks. And those changes are definitely significant. And as a result, the nurse have to know what's normal versus what's abnormal. Remember, make sure you know what's normal versus what's abnormal, because you need to know when to notify the physician. If that client is 2 days postpartum and their white count is 15, are you calling the physician? No. Are you calling the physician if 2 days post-op and the white count is 15? No. You better not, because I will give you the look. Okay, anyway, keep it moving. Give it without my questions. The nurse, also the focus of postpartum nursing care is that you want to focus on assessing physical recovery, monitoring how the client adjusts emotionally, and supporting bonding and attachment like we talked about in chapter 15. And the other thing that you're going to be noting is you're going to pay attention to how the family is adapting to this new birth now. Now, whether it be the first birth or a multiple birth, you're still going to assess how the family is coping. And notice I say family, okay? You're going to assess comfort, nutrition, and self-care, and also the need for contraception. You're going to be educating the client on contraceptive use, if that's even a desire. If they do not desire to get pregnant or anytime soon, what are the methods that they need to employ to avoid getting pregnant? All right, moving forward real quick. So the postpartum landscape, you must note the what happens from physiologically and also psychologically, okay? After birth, again, there's many physical and emotional changes. The goal is basically to promote healthy adjustment, detect if there's any complications. Again, you're detecting any complications and you're trying to reduce any discomfort that may occur, and you're educating a lot, and you're being that support system for that client as well. But your assessment, key thing here, your assessment begins within 1 hour after birth. And when does it continue until? For how long? After 24 hours. Nope. Until the patient is discharged. Say it louder. Until the patient is discharged. Until the patient is discharged. Assessment begins within an hour up until discharge. Okay? What happens is they're critical within the first 24 hours. It's just critical. All right, so know what's normal. Like I said, early detection prevents complications, especially serious complications. And your assessments, you need to know when you do your assessments. Usually within the first hour, you're going to be assessing every 15 minutes within the first hour, like I have here. Second hour, if there's no complications, no issues, you're assessing every 30 minutes, like I have it here. And then the first 24 hours, again, if there's no complications, you're assessing every 4 hours, okay? And after 24 hours, you're just following facility protocol. We just learned that depending on the issue, some facilities, they monitor like lochia, a different way, and they have different parameters. So you're going to be following facility protocol, okay? What are you assessing? I know I said I said the frequency, but I want to know, what are you assessing? Brent, give me an assessment.
Heart rate.
Okay, so vital signs, generally heart rate, blood pressure, okay? What else, Torres?
Breathing.
Okay, breathing, respiration. That's still part of vital signs.
Okay, vital signs. Yeah. Hemorrhaging.
Okay, you're noting. What else are you assessing?
Infections.
CBCs. Labs, good. Katie, what did you mention?
When?
I don't know, in terms of assessing. Oh, was it Avery?
I said bleeding.
Bleeding. How am I going to monitor for bleeding?
Labs.
The peri-pad.
The peri-pads. Very good. Okay. Now, of course, what you're going to do is make sure you look at the medical history. Again, your medical history is going to determine how the client is baseline, pre-pregnancy, and what are the changes that happen during pregnancy, and you're going to note the changes that happen right after delivery, okay? You're checking for pregnancy and labor complications, and you're going to make sure you take note of any treatment that was received by that client. You're noting for danger signs. Again, some of those danger signs that you are going to be looking out for is for signs of infection. And remember, you're making sure you pay attention to the timing, okay? You're gonna look at heavy bleeding like you mentioned earlier. Abnormal vital signs. This is why you're getting a baseline at each time frame to note the baseline, any variation from the baseline. You're gonna also assess for pain and the severity of pain. We just saw in that little clip how the client was complaining of abdominal pain, and that was ignored and what that led to, okay? And you also are going to assess for emotional instability, believe it or not, because they are going through emotional roller coasters. Not just the birthing parent, but also the partner as well, okay? So you're making sure that you focus on physical recovery, emotional well-being, any risk factors, early detection of any complications, and how the family is adjusting. Very important that you note that, okay? Now, vital signs that distinguish that, they're recovering, or there is an emergency that needs to that we need to pay attention to. I just put that here. Hopefully this is helpful, okay? Green light. It's expected that the patient goes into bradycardia, okay? So you can see that the heart rate goes in 52. So when I put a vital sign of 52 and you notice the timing, you need to know what you're going to do during that time. Valanda, just one day post-op, you happen to notice the heart rate is 45. What do you do?
That's insane.
Huh? Did you say just move on?
That's too low.
That's too low? So what you gonna do?
Stimulate.
What you gonna do?
Stimulate what? Oh my God, Schmidt
Huh?
the patient.
What?
Schmidt said stimulate the vagus nerve.
No, wait. When did I say
Okay,
that?
please.
When did I say
You
that?
trying to stick your finger on
When did I say that?
Schmidt,
When did I say that?
You know what? We gonna leave that alone. What would you do? Oh my! Make sure Schmidt not your L&D nurse.
I'll run.
Okay. What you gonna? You said what would you do with a heart rate? Remember, and I said one day post-op heart rate is what I said 45.
45.
What do you and you said it's too low. What you gonna do? So what you gonna do? Don't ever choose do nothing. Continue to monitor. I'm gonna I gotta make sure I watch this clip, and I'm gonna put as an option, do nothing. Okay? You never ever choose. NCLEX never want you not to do nothing. Okay? You just continue to monitor and keep it moving. Okay? All right. Make sure you know the temperature up to 100.4 degrees is okay, again, within the first 24 hours, okay? Remember, now, if you see that the temperature is going up to 100.4, just because you know it's normal, don't mean you don't really do nothing, okay? Offer some fluids, oral hydration. You don't need a prescription to get a patient something to drink, okay? You just don't. I'm gonna put an option. Okay, I'll get a prescription for oral hydration. Okay, you don't need a prescription for that. You don't want the temperature to go any higher anyway. You want the patient to be afebrile, not febrile as much as possible. Even though it is a normal physiologic response, what we're not going to do is give medications like Tylenol and stuff like that. Okay, you don't want to give antipyretics. You don't start giving antipyretics until above, the current literature said 39 degrees. And then the blood pressure is stable or near baseline. This is the green light to tell you that my patient is good. She Gucci, Ferragamo, and Prada. But I know I'm rolling in a Chevy Malibu.
Mixing clean and dirty oil.
Mixed with clean and dirty oil. I'm in danger when I see this. Okay? I know we're going to have a problem, okay? I'm driving a Chevy Malibu when I hit these numbers, okay? My oil ain't clean, all right? All right. okay? All right? When I notice, I mean,
You ain't the
Straight,
only
bro.
one that did it. And my Toyota, it did the damn thing.
okay, hey, it drove me from point A to point A and a half, okay? This, when you start seeing these results, this is when you're going to start to intervene, okay? So your book, again, oh, I lied when I said a book didn't go. They're saying when you're above 38, that's when you're in danger, okay? Now,
38 and 39.
no, I just realized the book does go over 38. Say it's over 38. My bad, we're gonna go with 38. But the literature does say 39, okay? So I'm gonna give something crazy, don't worry, not close to 38. I know I'm gonna be petty, but not that petty, okay? Other thing too is orthostatic hypotension, and you're noticing these signs and symptoms, several headaches, blurred vision. You see right here? Your mama should not be experiencing calf pain at all. Why are these people looking at me?
DVT.
Watching you teach.
Oh, okay, all right.
I'm about to close.
I mean, they went through, okay? And they should not have shortness of breath after pregnancy, okay? Don't blame me. Why you said?
I said PE.
Because of Okay, that 8:30 is helping, okay, I know, right? Okay, he's awake. Okay.
already got acknowledged once.
Okay. All right. Let him, because he ain't gonna get this highlight anymore. Okay. Okay. Remember we said you are in pre-eclampsia when what happens? What?
Headache and 140.
What?
Blood pressure. 140 over 90.
Good. Headache and a blood pressure of greater than 140 over 90. Very good. All right. Okay. All right. Okay. All right. And let me see if y'all remember. Low blood pressure can indicate what? Infection and hemorrhaging. Okay. Or it could also mean dehydration too. Okay, we said that as well. So, okay, y'all pay attention. Very good. Oh, I didn't mention that too. Also, in your book, it does mention that in this chapter, it does mention that low blood pressure could also indicate shock. Okay, y'all should know that from med surge. Okay, don't play with me. Okay. What else? Now, if you do suspect, here goes your med surge. Okay, let me see who I'm gonna call on.
I just calling Schmidt.
Well, okay. No,
I done shined already. I heard Seti talking a minute though.
Lexi, your client, you suspect that they have a DVT. You see that swelling, it's like right there, and because you did your job.
Massage, bro. Go ahead and massage that.
You're so stupid.
Massage that shit. We're gonna make sure we squeeze it up. Straight to the lungs.
I can't stand y'all. I cannot stand y'all. Lexi, back to Lexi. As the great fantabulous nurse that you are, you did your due diligence. You were rounding and you noticed, hey, one leg is bigger than the other. Are you going to do like Schmidt and massage that leg? Why?
Because then they would die.
Good answer. Okay? Schmidt, don't play with me, okay? All right? So how do you intervene when you suspect DVT of the lower calf? What do you do?
I would call the provider.
Definitely you're going to call the provider, but before you call anybody, because remember, NCLEX, these NCLEX questions don't want you to be so quick to... don't be so quick to call somebody, but you will notify the provider. In addition to that, what will you do before you call anybody? This is med surge.
Lizzie was business.
What she say?
Oh, are you saying, is Lexi saying Lizzie could help her sister out?
Yeah. What you said?
Yeah, kind of.
Okay.
Yeah.
Oh. When I don't call on her, that's when she's all into.
You called on me earlier and I answered your question.
Oh yeah, that is true. You're bad. Okay, you're bad. Okay. All right, very good. So yes, you do elevate. I was gonna say elevate the head of the bed. No, elevate the leg. Okay, and making sure Yes, you will notify the physician because again, this is a suspicion. And what would you expect the doctor to order now? Wait, before we get there, okay. Damn, she really bringing on med surg, boy. She like, Dr. Sebi, don't play with me, okay? Before we do that, we just suspect that it's a DVT. What would you expect the doctor to order now? Okay, to confirm. Okay, you need to validate before you intervene. Okay, very good. Also, you're going to be managing pain, etc. Perineal care, providing rest, fluids, and analgesics as necessary, okay? All right, moving forward. Oh, y'all coming for a review? When it comes to OB, listen to me well. For NCLEX purposes, you cannot go into NCLEX not knowing the bubble for OB-related questions. Okay, you want to call it buble? Call it buble, okay? You do need to know the bubble, okay? After when you pass NCLEX, on your very first attempt, what you do with that information is whatever you do with that information. But you do need to know the bubble. This is your assessment. Okay, postpartum, this is part of your postpartum assessment. Let's go over it. The bubble. First B, definitely you're going to assess the breast. Okay, you're going to note the size like it says here. You're going to note the nipple, if there's any redness, nipple cracks. You're going to palpate to see if it's soft, is it filled, or is it engorged. And note if there's any latching issues, okay? That's with the B for breast. Then you are also, with regards to the breast as well, you want to make sure you note any normal changes, like does the milk start right after placenta delivery? It should. And the breast should be feeling firmer when the milk comes in. All right, that's the main thing. For parents who are not breastfeeding, you want to avoid breast stimulation. Schmidt. Okay? If you do not want to breastfeed, okay, if mom does not want to breastfeed, avoid breast stimulation because that will stimulate milk production. All right, the uterus or the fundus, you want to make sure it's at the top of the uterus and it should be where? How should it be? Firm. Where should it be? Midline. And it should be gradually moving which direction? Down. Okay, very good. Natural or normal progression should occur within 6 to 12 hours after birth, and it should at that time it should be at least at the belly button. And remember, we said earlier it drops how many centimeters? 1 centimeter per what? Per day. Okay, very good. All right. Should you feel it by day 10? 15? No. Okay, because if I do feel it by day 15, what's that indicate? Okay, another baby. Well, let's just hope that it's just another baby and not hemorrhaging, okay? Dangerous findings, again, include boggy uterus, which indicates uterine atony, which we said earlier. Fundus is above the umbilicus, and if it does remain above the umbilicus, we definitely have to investigate further and also bring that to the attention of the physician. Uterine should be pushed to the, if the uterus is pushed to the right, most likely they have a full bladder. So maybe if they urinate, that helps empty the bladder. Usually that helps, but if not, then it could be boggy. If it is boggy, what are we doing for a boggy fundus? Massage it until when? Until it's firm, okay? Until it's no longer boggy. All right, bladder, the other B, okay? After birth, again, you should have, you could expect large amounts of urine, up to 3,000 milliliters per day. The major thing, again, like I mentioned earlier, remember that some clients may not feel the urge to void, and that's why their bladder may have the tendency to be full. Okay? A full bladder could push the uterus upward, and it could prevent contraction. And remember, we need that contraction even postpartum, because that contraction helps alleviate or deals with preventing hemorrhaging, okay? with the bladder, warning signs that you are looking out for is that they are unable to void for especially the first 6 hours, okay? Within 6 hours, they should be voiding after delivery. If they're not voiding, then that's a problem, okay? So you better pay attention to the time. I keep mentioning, pay attention to the time. I might include an actual time, all right? Burning or peripheral urination, feeling bladder not empty, and then the round mass above the pubic bone. Those are all warning signs that indicate that the mom could be in danger. All right. Now you are also looking at the bowels. Remember, constipation is normal, so you know what to do. Give some fiber, some fluid, go get up and walking, etc. Right. But you want to make sure you reassure that patients that they won't. You want to include measures where they don't rip any stitches if they have, especially like in the episiotomy. So this is why you want to give like a stool softener. Lochia is the discharge that we talked about again, and remember, it's going from dark red to very bright. Okay, it should not go the opposite way. Okay, if it does go from alba to rubra, we know we're in danger. Okay, the other thing, like we mentioned earlier, that foul odor, infection, it could indicate infection, like Katie was making sure we talked about, we mentioned. All right, perineum and the extremities. Again, you're assessing the perineum to check for edema, bruising, or hematomas. Just remember REEDA, REEDA, redness, edema. You're looking at the episiotomy site. You're also looking for drainage and amount, A for amount. So those basically what you're looking for. But again, you're definitely paying attention to know if there's any DVT, okay, that cough. So this is why part of your assessment is going to include measuring the cough. Remember that. I know it's not explicit in the book, but you should remember this from Med-Surg. Part of your assessment will include to measure the cough, both cough, because they should be the same. Yes. You're noting for symmetry. If one cough is bigger than the other. Now, sometimes in rare situations, you may have where both cough is much bigger than before. This is why, again, you're getting your baseline assessment and to note that any changes in variation. Are we cool? Yes. Okay, very good. We already talked about this, bonding versus attachment. Again, the main thing with regards to bonding that was not mentioned earlier is that bonding could be unidirectional, which basically means you see the bonding between the parent and the child. Okay, that's basically what that means. Okay, bonding, the sooner it happens, the better. You want it to happen within the hour if there's no contraindication, because that bonding that happens between the parent and the child also helps with the neonatal development. Okay, so you're looking at the fingertips, you're looking at how they touch, you're looking at how they hold the baby, all that stuff. Okay, you're looking at how they emotionally attach themselves to that child as well. Hence the attachment between parents and infant. Okay, again, it could be reciprocal. Usually it's reciprocal. Okay, usually it should be reciprocal. Okay, in the rare circumstance, the baby may not want to deal with either one or both parents. I don't know of any situation where that happens, but hey, you never know. The only thing too, the time frame, there is no set time frame. It's progressive in terms of the attachment that happens between parent and infant. It may take longer for that attachment to happen, for some than others, all right? And then, of course, what happens with the attachment, it does go through stages where you see proximity, where they get close together, that's that bonding, the reciprocity, where you see parent gave it to infant goes back to and give it back that same love to the parent, and then they go into what's called commitment. They're sticking it through no matter what. That's basically what's happening here. We already talked about cultural competent care. Okay, just make sure, again, different cultures show how they bond differently. Different cultures show bonding differently. Okay, so you're going to see some interesting things. I might give an interesting complex scenario, but you got to make sure you know that if that's part of their culture, then it's part of their culture. There's no harm as long as there's let me backtrack. As long as there's no physical harm to the child, you know what I'm saying, abuse, of any sorts, then we know we're fine. That's just the way they bond with the child. Okay, they might have some ceremonial practices. For example, like is it Jews that they do the naming like within 8 days? Is it Jews? They don't give a name for the child. I think it's Jews.
What do you do with the birth certificate?
They hold it. They do it later on their own.
They put baby.
Yeah, they'll put like if the parent's name is Ricky, they say baby Ricky.
Well, either way, they never. It's not like in the movies where they tell you, well, who you want to name them right now. It's always like, here's the number for security number for the security officer.
At Longwood, they do.
Every facility is different.
Yeah.
So that's why I'm saying you want to make sure you respect the patient's culture. Basically, you want to make sure you respect the culture, you provide strong family support, and you encourage rest, okay? According to the cultural practices. Remember, some people rest for weeks and months at a time. It's going back to what Brant mentioned earlier. Please practice cultural humility, okay? You want to know. You have to have that willingness to learn. This, you must know, assessing the bond, the interaction between baby and child, basically. Positive signs show you that there is bonding that takes place where there's direct eye contact. Again, with respect to the patient's culture, because not all cultures do eye contact, okay? There is like, they're exploring the patient, the parent is exploring the baby, they call the baby by their first name, or they might have a little nickname or, little play name for their little baby. So you see that there is some positivity in terms of the bonding taking place. It is strong. Negative indicators that bonding is not taking place, in other words, maladaptive. This is where the parent has apathy, they avoid eye contact. Again, eye contact with respect to the patient's cultural background. There's disappointment, and they fail to explore the infant. They don't really want to get to know that child, okay? The child could be crying like morning, noon, and night, and then they do not attend to the well-being of the child. So that could be an indication that there's maladaptation taking place. So you want to make sure you observe, you want to model positive behavior, and you want to provide support. And you're being non-judgmental, because there could be different factors that leads to that maladaptation. Okay. Part of your teaching or your discharge teaching, it could be part of your teaching, or this teaching could be done at discharge. You want to educate on how to provide perinatal care using the peri bottle. Warm water is preferred, okay? And remember, it's front to back with every single void, okay? Comfort, you want to apply ice packs within the first 24 hours. You can use a sitz bath after 24 hours for the most part. Sleep strategy, of course, you're incorporating rest, and then, of course, you want to rehabilitate that pelvic, that muscle and stuff like that. So you do the Kegel exercise to prevent incontinence, all right? We're incorporating breastfeeding if that's what the parent wants. Listen, it's the parent's choice whether they choose to breastfeed or bottle feed. There's pros and cons to each method, but it is the parent's choice, okay? When it comes to breastfeeding, in addition to holding it a certain way, make sure you pay attention to the timing, okay? So, of course, you're doing the kangaroo contact right after birth, okay? You want to make sure, of course, you dry the baby, assess, and you do the kangaroo. When the baby is on the mom, of course, breastfeeding should start as soon as possible. Of course, you respect the policies as it relates to breastfeeding. Everybody should be very well educated. Now, before feeding, you're definitely washing the hands. You're teaching mom, wash their hands. Be comfortable and relax. Feed when the baby shows signs of hunger. Some signs of hunger will be what? Crying maybe, yawning, okay? So make sure you know those different signs of that the baby is hungry, and you can expect stronger after pains during breastfeeding. In other words, you're educating mom what to expect, because that pain could also be stronger. Now, while feeding, you're holding the breast in a C shape. Okay, just like how you see here. This is during feeding. All right, you tickle the baby's lip to open it, or to open the mouth wide open as much as possible, and then to bring the baby quickly to the breast while the mouth is open, and then you're listening for swallowing. That's the main thing while you're breastfeeding. And then to break the suction, you're going to just break it gently with a finger when removing. After feeding, now you're going to burp the baby, and there's different ways that baby is burped. They simply put the baby. One method is putting the baby on your shoulder and then lightly tap it. Switch breast. You want to encourage mom, if you use the right breast this feeding, use the opposite breast the next feeding. Okay, that helps with that engorgement and that breast discomfort. And then you also want to make sure you cheer. Be a good cheerleader. Okay. Remember, the frequency should be on demand. Typically, it's usually every 2 to 3 hours. Typically. All right. Lactation, you want to make sure you help with lactation. Some common issues could be engorgement, and if there is engorgement, you just know that it can resolve on its own within 72 hours. But what you can do to help with the engorgement is frequent feeding, massage that breast, and do manual expression. If there is sore nipples, you just want to check how the baby is latching on and apply breast milk sometimes to heal with the sore nipple. And you want to mainly avoid soap, especially those soap that can have a huge drying effect, all right? And then also a high BMI, okay? Anything above 30, it could be a problem. So you want to use the sandwich technique, in which you encourage the frequent feeding. I know it says sucking, but I don't know why I put it that way. But you definitely need to know who is contraindicated from breastfeeding. This you gotta know. HIV. Parents who use illicit drugs like opioids, coke, PCP, for example, any drugs, because it's going to pass through the breast milk. With the exception, now the book does mention with regards to drugs on page 505, with the exception of those who are stable on methadone treatment. You see that? So I just want to make sure when you see that, you don't come for me, all right? So again, do not breastfeed if you're on illicit drugs, with the exception of those who are stable on methadone treatment. Those who are stable on methadone treatment can breastfeed, okay? Like we mentioned earlier, HIV and is not on treatment, definitely. Especially if they're not on any antiretroviral therapy, they should not be breastfeeding.
So the methadone doesn't transfer?
According to the literature. According to the literature.
Methadone is just like a lower dose for them to be able to not have withdrawal, but it's still meth. It's still meth.
But again, the key thing is that the client is stable. If the client shows signs of instability while being on meth, then you're not going to.
Monitoring the baby? Like, are we monitoring the baby though?
Oh,
like,
for sure. For sure.
Even though she's breastfeeding while on methadone?
I would assume so. I would assume so. Okay. Yes. Because again, you want to see how the baby is baseline, and you want to note any variation. But again, the key thing is the mom has to show signs of stability while on it. That's the main thing. But yes, you are definitely going to continue monitoring that baby frequently.
Because I know, like, same thing with crack babies, like we have to monitor them like extensively because it's gonna affect.
Yep.
But...
You all right?
Okay.
Yep, you're absolutely correct. Okay. Who else? Those who have active herpes on the breast definitely do not breastfeed.
It's not active, they still can.
But they said has active.
They should not from the affected breast.
Yeah.
Not active, they're good.
Right, but if it's not affected. So if they have another breast that doesn't have an issue,
that's good.
Yeah.
Okay.
Okay, per the literature. Certain infections, like the book mentions Mpox, brucellosis, godly, I butchered that one, active TB, and active varicella, okay? Now, it does say for TB or varicella that expressed breast milk may still be given to the baby.
That'll make no sense.
I know, I read that, I know. And it says it right there. With active TB or varicella, though expressed breast milk may be fed to the infant, and that's according to the CDC 2023.
That's Confucius, because tuberculosis is airborne. That's for number one. And I understand maybe the varicella one just because of contact.
Right.
But tuberculosis is airborne, so you shouldn't even be around your baby in the first place. Yeah,
In the book.
please verify that because that is just sounding a little too.
Assess the breast after birth, okay? Teach the patient to check their breast every day. They should be looking for fullness, like milk coming in, nipple condition, and signs of breastfeeding that it's working well. And they're also assessing for pain or hard areas like we mentioned earlier. The breast may feel soft, which is usually seen in the early on, feeling. Well, that means that the milk is coming in and engorged. And remember, engorged means that it's very hard, swollen, and painful. So make sure you read up on breast engorgement as well, okay? Now, if the patient decides, the birthing parent decides to bottle feed, it's their choice. That don't make them a bad parent just because they use formula, okay? It's not doesn't make them a bad parent. Some people like to think otherwise. It is okay. When the birthing parent decides to bottle feed for whatever reason, make sure you as a nurse, you know that it is the parent's choice and that there's different types of formula, which include cow's milk-based formula, soy-based, and specialized formulas. You have the specialty formulas for patients who have either allergies or sensitivity to the milk sugar, galactose, that one, okay? If they do have sensitivity or they do suffer from, the baby rather, specifically, if they do suffer from galactosemia, they have to have that special milk, okay? Just know that the formula, according to the book, it comes in different forms like powder, concentrated liquid, ready to use. Just note the difference between breast milk versus formula. With breast milk, the breast milk can change over time. Please tell mama that, okay? Do expect for your breast milk to change. That doesn't mean your breast milk went rotten or sour. No, okay? Your actual breast milk that comes out of that is just basically that change happens because it is adjusting to the baby's need. Formula, the composition is going to remain the same regardless, and it's basically you have to meet the needs it's meeting the basic needs of the child from birth even up to about 12 months, okay? With formula, it have the different nutrients such as carbs, fats, proteins, and the different vitamins and minerals, etc. But parents may need to change the formula as the baby grows. That's very important. So the formula that they were using when the baby was first born may not be the same formula that they use when the baby is like 3 months or 6 months of age, etc. Okay, it all depends on the needs. How much the baby need? How much does a newborn need with regards to feeding? It depends. Usually, it's about 110 to about 135 calories per kilogram per day. So it's weight based. And it does provide 20 calories, the formula, but usually most newborns just need about 2 to 4 ounces of formula per feeding. 2 to 4 ounces. Don't be extra with it.
Tell me whole one.
Okay. And that is usually when the baby is about 4 months, they say. Now, you know, in certain cultures, that's not going to be respected, and we just gonna leave it at that. Okay. When
the solids?
Huh?
The solids you said?
No, the amount of formula.
Yeah,
The
that
amount.
also plays into it because I know a lot, like in Hispanic, like my family, they love to throw rice, like the whole meal.
Oh my God, that is not just limited to Hispanics. I think that's a whole Caribbean
And
thing.
I'm
My
finding
son
out
was on
now.
breast cereal in 3 weeks.
Yeah, and I'm finding out
You
now.
too?
He would not get off the booby. I had to put a little teaspoon in there.
Yeah.
So yeah, okay. Again, when it comes to bottle feeding, wash your hands with hot soapy water. Make sure the nipples of the bottle and the bottles are clean. When preparing the formula, please. Yes, in addition to washing your hands, but it gotta be room temperature water. It can't be like boiling hot. Thinking like you're doing something. Well, you are doing something. You're killing the formula, okay? Refrigerate any prepared formula, those that remain unused. But if they do not, if they have some remaining formula, how long is it good for? For an hour, no more, no, an hour. Once it's prepared formula is good for up to an hour, okay? After that, listen, tell mom, parent, loved ones, any caregivers, throw that thing away. It's no longer good. For formula, okay, for formula prepared milk. Huh? Say it again?
And they may just not care because that formula is expensive.
It is. It sure is, okay? And then, speaking of expense, you know what some families would do? Dilute that thing, okay? I mean, hey, when the struggle is real, it's real, okay? You know, we gonna make things happen. We gotta make things stretch a little bit, okay? So some people do dilute it, but what's the problem with diluting it?
They're not getting their full nutrition.
And it could cause water intoxication, okay? So you wanna not dilute it, okay? All right, I already told you how to hold the baby and all that good stuff. Now, resuming normal life after delivery. Again, you're making sure 2 to 3 days after discharge that hold on guys, that they do get vaccinated as necessary, okay? Some of the vaccines do include rubella vaccine. RhoGAM, they want to give RhoGAM if the baby is Rh negative, giving birth to an Rh positive.
Oh, if the mom is Rh negative.
Yes, if the mom is Rh negative, huh? You do the Coombs test to determine that. But you need to know when you would give the RhoGAM or when you would question it. And I made sure I looked at the literature, you know, the OE books. It has to be specifically, because I thought, what if the baby was Rh positive and the mom was Rh negative?
No.
I mean, what if mom was Rh positive and baby was Rh negative? Then we good. Yeah. Because she's developed, an Rh positive mom has definitely developed the antibody, so she don't need the RhoGAM.
It's only to protect mom anyway.
And so, because she's developed, an Rh positive mom has definitely developed the antibody, so she don't need the RhoGAM. Go ahead, Ashley. And so, okay, quiet in the house. Shh.
I would say B.
Okay, you didn't even read the options.
What question is it?
Oh, I just wanted to see what I was gonna
Dude,
it's not different.
Not Sarita getting mad at Ashley's question. Why you say B?
Because when this is boggy and the pad is saturated in 45 minutes, it shouldn't be that saturated that much, so it means that they're hemorrhaging.
You made it to the right.
Look at the post that you put in there. 58.
Okay, see? Don't say, okay. Sarita, since you would be mad at her question, let's go.
I just was just saying that I need
I
to
know. There you go.
Hold on, I gotta write it down. Okay, one moment, please.
Who said that? Who else?
I'm gonna say.
Damn, okay, so I'm gonna say A and E for sure.
Okay.
Can we go back to condoms being the best option and like birth control and stuff? This one's too advanced. Right.
Do you guys think B?
I thought I said A and E. Oh, I'm going back up now. Okay, B, we're gonna scratch off, okay?
Okay.
Can you scratch it off so I can see?
Oh, so you want me to scratch it off? Okay.
Thank you.
Okay.
Here, take this marker.
Take F out.
I had borrowed this from somebody.
Oh, it's my bad.
Borrowed.
You took. You snatch it.
I'm gonna choose B as one of my choices.
No. That was wrong.
I'm still going. I'm still going.
Progesterone.
I don't know about estrogen.
I saw something like that in the book. I hope
It's C. It's C. I just found it in the book.
Bruh. Okay, because of that, we stayed an extra 30 minutes.
No, wait. Erase B. We're gonna go with C.
Erase B. So you're going with C.
We're gonna take off B.
We're taking off B. Oh.
I'm gonna say F, because combined pills can decrease milk supply. I'm gonna say that.
Are you still keeping E?
I'm gonna keep E.
So your final answer?
That's right. I guess that's what we're gonna go with.
A, C, E, F. Okay, let's see if we staying here for 30 minutes.
What? Why does mine have to write on that?
I don't know. A, C, E, and F. Okay. Period. Okay. We all understand? Teamwork does make the dream work.
If you want to know where it's at in the book, it's page 503, bottom left paragraph.
All right, 503. Liz, next one is for you.
Well, they have moderate rubra, which is still fine on day 3. Fundus is firm. Ooh, the fundus hasn't gone down enough. That's it. They're on day 3, and I think that U/1 just means 1 centimeter lower. Am I wrong?
I have no idea. I saw that too. I don't even know. I have a purpose.
You know what I'm saying? Like, is it only 1 finger under the belly button?
Yo no
That's
sé,
still-
no me sabo.
That's still pretty high.
Pretty hard.
And the pulse is high.
You shouldn't have that rate of pain
Over
at 3 days
100
postpartum
is
either.
a red flag.
Yeah, definitely.
And while Elizabeth is figuring out part 1, Steph, figure out part 2.
We're gonna go with B for part 1.
So part 1, you say B.
Yes, because uterine anatomy would have a soft uterus, so A is ruled out. Endometritis, nothing in that documentation is talking about foul discharge or anything like that, so we're gonna rule that out.
Okay.
Normal postpartum changes, that's also incorrect because that pulse is high. So the only one left by process of elimination is B.
Okay, so part 1 equal B. And then part 2, Steph, you got your answer? You say C. Why you say C?
Because, okay, I don't like that it's bluish discoloration. I mean, I know it's swollen, the pain is too high. I would like the doctor to look at it, because what do I know? I don't like that.
Okay, so you're calling the doctor because you don't like what you see.
But is this a scenario where we have
Discoloration, what if?
You have to pick something, yep. You mean from each of these answer choices?
No, I mean, like, you know how you were saying, like, NCLEX doesn't like for you to just.
Notify the provider.
Without what? Choosing an answer choice where the nurse herself or himself can safely take care of the situation themselves.
You guys, the answers on page.
Okay, B and C. Let's see if they're correct. Very good. It is correct. Part 1 is B. Okay. And part 2, the correct response was C. All right, because of that severe pain. Yes.
Which option was C? Was it call the doctor or?
Call, notify the provider. And Steph was correct.
A warm compress, because if you already have a hematoma, then a warm compress
Will make it worse. Very good. All right. And then what will happen if you are dealing with this situation? Guys, what would happen if you are dealing with this particular patient and you massage the fundus?
Won't it make them bleed more?
You're right.
That fundus is already firm. Why are you gonna massage it?
Is there even how's the fundus? It's firm. When do you massage the fundus? When it's boggy. All right. Okay.